Hi everyone, and welcome to today's webinar. Today we'll be looking at data collection with Dr. Nikky. But first of all, I'd like to welcome you and acknowledge the traditional owners of the lands where we meet. I am on Whadjuk Noongar country, and I pay my respects to the elders past, present, and emerging. I pay my respects to all Aboriginal people and anyone present in the room. I pay my respects to their resilience, their courage, their self-determination, and I stand beside my Aboriginal friends and colleagues today. And today we have with us Dr. Nikky Gordon. She's a postdoctoral research fellow with Solve's PhD program at UWA. As a clinician and researcher and accredited exercise physiologist, Nikky is in Geraldton, so she understands that rural and remote aspect of care. And she has a keen interest in improving access to cardiac rehab and secondary prevention programs, especially for disadvantaged populations. Nikky's worked clinically for over 10 years in the public and the private system, and including running her own clinic, which focused on cardiovascular conditions in metro and rural locations. That was from Murdoch University. Yeah, Nikky. She has active advocacy roles that aim to improve equity both for health professionals and patients in healthcare. The current research focuses on improving access to cardiac rehab and secondary prevention programs utilising co-designed digital health and technology. So welcome today to everyone. You've come from all over WA, which is fantastic. We've got Newman, Albany, Esperance, Kalgoorlie, and lot everywhere in between represented. So that's fabulous. If you've got any questions, please pop them in the chat. And then at the end, you can come off mute and ask Nikky the questions. So I'll pass to you, Nikky. Thank you.
Thank you, Helen. Excellent. Thank you, everyone, for showing up. Hopefully the sound is okay. I just noticed when you're speaking then, Helen, it was a little glitchy. So hopefully I'm still coherent. And I will try my best not to talk really fast, although I tend to do this when I talk about anything on webinars. So I just start by acknowledging the traditional landowners on which we all are meeting from today and pay our respects to the elders past, present and emerging. So today what I'm going to go through is some results from a survey that we conducted a few years ago on a national level. And today I'll be going through our secondary analysis from the WA only respondents. So are we talking about why we did that in the first place, what we did, what we found, and then some concluding remarks and recommendations. And I'm preaching to the choir here, but just to set the scene, I will reiterate really quickly. So heart disease affects more than 4 million Australians and accounts for 45,000 deaths per year. In 2020 to 2021, heart disease cost the Australian health system $14.3 billion. Secondary prevention, such as cardiac rehab, cost effectively reduces hospital readmissions and deaths from heart disease, while also improving physical function. However, these outcomes are only associated with services that are of high quality. So what makes a service high quality and how do we determine this in clinical practice? So in line with global efforts, Australia recently proposed 10 national cardiac rehabilitation quality indicators. These refer to process of care shown in the purple and include things like timeliness of referral and completion of a comprehensive assessment, as well as having indicators related to outcomes from cardiac rehab. So assessment and change in exercise capacity and health-related quality of life. National indicators are used to assess the quality of cardiac rehabilitation services, benchmark their performance, and to drive quality improvement. Within Australia, Queensland and South Australia are the only states which have electronic registries for standardised data capture and management that allow assessment of cardiac rehab quality and improvement processes. WA participates in several national clinical quality registries, including the National Cardiac Registry for Percutaneous Coronary Interventions, but currently we don't have a system for quality assessment and improvement within cardiac rehab. So the aim of this report was to describe the current practices of data capture, management and use in WA cardiac rehab services, as well as perceptions and use of the national quality indicators. The descriptive survey design was used to collect data from cardiac rehab services across Australia between September and December 2021. 45 services were identified and contacted within WA. And this is the results of those services that we'll be looking at today. For the purposes of this project, a cardiac rehab service is defined as a multidisciplinary, multi-component service. Those services focusing on inpatient education or solely providing heart failure services were excluded from our analyses. And the results from the national overall survey were published in 2023. Nationally, electronic systems were categorised based on their capacity to support quality improvement across jurisdictions. These categories were created by consensus among 4 of the investigators and included patient management systems such as NUCL, patient treatment systems such as CardiHab, electronic medical records and quality improvement platforms, which is QCore that we found in Queensland and Catch in South Australia. This is a table of qualities of the different electronic systems. And if we look at the red highlighted box, one of the qualities being support for systematic, accurate data entry with pre-specified fields and drop-down menus. This is a quality for quality improvement platforms and worksheets. I don't know if you can see my mouse hovering over the screen, as well as patient treatment systems. It is sometimes a quality of electronic medical records and patient management systems. However, this is very system dependent, as this quality is generally not something that's found in patient record systems. So going through our secondary analysis of the WA responses to the national survey, we're going to look at service characteristics and how we compare to the national averages, data management methods, uses of collected data, and then having a look at the quality indicators. So this is a table of the service characteristics in the first column. Our WA data is in the second column. So the first number is just the number of respondents that answered to that particular characteristic. And then in brackets is the percentage. And then the third column is the national published data. So in WA, we had 39 out of the 45 programs respond to the survey, giving us an 87% response rate, which is really good for a survey. The national response rate was 81%, so slightly above average. We'll take that one. A few other interesting things of note is the proportion of nurse to physios in WA is essentially flipped on the national data, which I thought was quite interesting. We also have a much higher proportion of private services. So we have 35.9% private services in WA compared to 23.1% as the national average. Interestingly, only 3 out of the 14 private services in WA are hospital-based. And while I don't have the data on this, I'd say that's much lower than what we would find in other states. Given the sizable proportion of our state that is non-metropolitan, the lower proportion of programs in rural and remote towns demonstrates an opportunity for new delivery models to improve access to cardiac rehab. Since this survey was conducted, the Heart Healthy Support Service, formerly the Virtual Cardiac Rehab Program, has been rolled out for WA Country Health Service residents in the Wheatbelt, Southwest and parts of the Goldfields region. This service started in October 2022 and links patients with specialist rehab nurses via telehealth and can also link patients with further local support. Right, moving on to the data management methods. So 4 in 5 services in WA have access to an electronic system or website to document clinical information and measurements. However, this is leaving 1 in 5 services that are doing everything completely paper-based. At the time of the survey, there were 14 different systems being used, with the most common being SHIMS XL and BOSNet. Having said that, the WA Department of Health is leading the electronic medical record rollout of BOSNet/Opal across all public health services in WA, and this is due for completion this year. When we look at the electronic system categories that we saw a few slides back, the most common categories in use in WA were the patient management system and the electronic medical record. The electronic medical records systems are statistically more likely to be used in public services, with patient management systems statistically more likely in private services. Of the software systems used by services, none are considered quality improvement platforms, aka the gold standard, and only 7 services use a quality improvement database of some description. While the proportions of paper, electronic and combination methods vary across the cardiac rehab journey, around at least 1 in 3 services will enter data directly into an electronic platform. This is shown in the green slices on the graphs at the bottom, with the number inside each slice representing the number of services. On average, 3 in 10 services use paper only, which is the orange pie slice, and 3 in 5, this goes up to 3 in 5 using paper at some point, so the combination of orange and the yellow slices. The yellow slice represents double handling of data, so using paper then scanning into or entering into an EMR, and this is not efficient or ideal, and that's a lot of time spent on this process. And then when we look at record storage after someone has completed their program, just over half are using paper at some point, but there are quite a lot of services that will enter their data directly either into the EMR, shown in the light green pie slice, or into a local laptop or computer, shown in the darker green. While assumptions regarding quality improvement activities cannot be made based on the data collection method, the current methods are not conducive with effective quality improvement collection and use. Standardization of data collection methods and content will drive consistency and transparency across services, while the use of preset fields and drop-down menus will ensure good data quality and reduce time resources. Looking at the uses of collected data, so 4 in 5 services will use their data for at least one of the reasons shown in the graph on the right, with the most common being a patient progress letter to a GP or doctor. Other uses include a report to the line manager, use to inform quality improvement activities, or support funding for the role or program. However, there is 1 in 5 services that are not using their data for anything, which represents a missed opportunity for quality improvement. Providing support to cardiac rehab services to collect and use their data to conduct quality improvement activities will advance delivery of high quality services. The collection and use of the national quality indicators will also build consistency and provide the ability to benchmark and compare services. Moving on to the quality indicators. So 3 in 4 respondents were aware of the indicators at the time of the survey, with the vast majority finding out through an ACRA conference or webinar. So the indicators were released on in June 2021, and this survey was conducted in September to December that same year. So there's not a whole lot of time between. So hopefully in the time since this survey was conducted, more people know about the indicators. Private organisations were statistically more likely to have knowledge of the indicators than public ones. So there may be a link between private organisations and ACRA membership, since most people found out of it through that. However, we didn't actually look at this in the survey. So this is just a hypothesis. Of those aware of the indicators, 56.7% found them to be useful or very useful, with 43.3% finding them to be neutral or not useful. Of those aware of the indicators, 4 in 5 provided the following reasons for not implementing strategies to collect the indicators, with lack of knowledge, aka only recently found out about them, being the most common one. Other reasons for not collecting the quality indicators are that they're already collecting some of them, the data are not required or used, or a perceived lack of usefulness of the indicators. Of those aware of the indicators, 7 used the following strategies to implement the indicators, including changing the spreadsheet for data collection, creating a letter template, regular staff training, setting aside time, using a staged implementation, and having the quality indicators embedded into their existing data platform. Other actions taken to collect the indicators included adding screening for depression and anxiety, sending a letter to cardiologists and patients, and conducting regular audits. In conclusion, this survey identified several inefficiencies and inconsistencies in data capture and management practices. Alongside the implementation of key state and national healthcare projects, it is an opportune time for action that could see significant long-term benefits to patient outcomes and healthcare system burden and expenditure. The findings from this survey, as well as the desire to improve patient outcomes, has led to the following recommendations. So recommendation 1, a standardised digital platform for data collection and use is recommended and should include the following features. It needs to be accessible to public and private services, make use of preset fields and drop-down menus, have the ability to create progress letters, allow collection of the quality indicators, provide the ability to benchmark performance and compare across services, and it needs to have capacity to link with other health service systems. The second recommendation is that services should be supported and encouraged to conduct quality improvement activities in an iterative and continuous process to ensure high quality delivery of cardiac rehab. Interestingly, this was something that was delivered in the Heart Foundation Health Professional Ambassador Program that unfortunately stopped with COVID and hasn't been re-implemented by the Heart Foundation or any other organisations as far as I'm aware. The third recommendation is certification of cardiac rehab providers and services. This will underpin consistent, transparent and high quality delivery of cardiac rehab. ACRA, the International Council of Cardiovascular Prevention and Rehabilitation, or ICCPR, and Solve CHD recently funded for completion of the ICCPR Cardiac Rehab Certification, which is an internationally recognised certificate to try and help with this recommendation. This recommendation is also the basis of a Heart Foundation Catalyst grant application, which is a top 20 finalist, and we are awaiting news of success, hopefully any day now. And the fourth recommendation is individual corporate membership with ACRA should be promoted to those working in cardiac rehab to ensure optimal patient care through access to and engagement with the latest advances in clinical practice and professional development. And a little shameless plug of current research that we've got going on. So this research really addresses recommendation 1. So we're calling it the EQUIP study, and we're looking to trial a low burden standardized electronic platform. Low burden in that it integrates into daily workflow. You complete it while you have the patient with you, not afterwards, requiring more time. So for example, if you're going to complete a depression screening, we've got included the PHQ 2/9. So you actually complete it while the patient is there. This platform will also support collection of the quality indicators, provide timely feedback to services, and facilitate quality improvement and advocacy. It does address most of the factors outlined in recommendation 1. So by using UWA REDCap software, it will be accessible to public and private services. We've made use of preset fields and drop-down menus. Cannot figure out how to create progress letters with REDCap. There's probably a way or some other easy way to do it, but I have not figured that out yet. It is aligned with the quality indicators, so you would be able to collect all or some of them, depending on the time you have with the patient. We are creating a dashboard that will give you the ability to benchmark your performance and compare across services anonymously. I put a question mark next to capacity to link with other health service systems. The WA Health currently isn't allowing automatic uploads from REDCap to BOSNet due to bandwidth issues related to their statewide rollout. However, you will be able to download PDF versions of the completed forms and then upload them to your electronic system of choice. We're doing this in 2 phases. So the first phase is to create the new platform using REDCap software. This is done. Still in the process of figuring out how to do the dashboard. Phase 2, we will pilot test this new platform for 3 months in up to 6 services. Hopefully, we're trying to get a mix of public and private, metro and rural, because we're going to conduct semi-structured interviews after the trial period. We're using the NAS framework, so the non-adoption, abandonment, scale-up, spread and sustainability framework, to describe clinician and service level factors that influence the uptake and continued use of the electronic platform. If this is something you are interested in participating in, you can email me on the email provided here. Do we have any questions?
Thanks, Nikki. Natalie, can everybody come off mute, please? And I'm also thinking, because we're a small group, it would actually be nice to go around the room and see what questions people have for you, Nikki. So, yeah. Oh.
Open to any discussions?
Yeah. Anybody got questions? I just wanted to confirm something for you, Nikki, that the ambassador program did not stop because of COVID. I ran the ambassador program through COVID online. The ambassador program was cut by the Heart Foundation when the leadership changed. So that might have impacted. But I've got lots of questions if nobody else has. And hopefully there's some that some of the people in the room might have been of. So Queensland have Q-Core and South Australia have Catch. Do you see this new RedCap software being able to do a similar thing that they do in their states?
Eventually, yeah. So we are in
Yeah.
the early stages, and I know there are some working groups that are working towards a national single
That's what I
platform.
was
So whether we can pull data from Q-Core and Catch directly into whatever system we come up with. They are also interested in piloting something similar to what the British Heart Foundation use and having a traffic light system based on the quality indicators that would be public facing. So if patients had the opportunity to choose which service best aligns with them, they would also have that information in the traffic light system.
So, and do the British Heart Foundation, do they have the same quality indicators that we have in Australia?
Not the exact same. There are a few differences, but yeah, I think these ones were created to try and really address the Australian context. I know in some others, I don't know if it's a British Heart Foundation, there are other quality indicators in cardiac rehab that relate to LDL cholesterol.
Yep.
But that's something that we haven't included in the equip one, particularly with the high proportion of private services that we have. There'd be a lot of services that don't have access to that information, and it doesn't necessarily get measured enough for you to say that the cardiac rehab program did result in this change, because most programs are 6 to 8 weeks long. And patients don't typically get assessed that frequently.
Yeah, I'll keep kind of freezing. Yeah, also that was interesting too around the private services and the links with ACRA, because I do know that Ramsay Health, pretty much all their staff are ACRA members if they work in cardiac rehab. So that was really quite interesting. The other thing that I found really interesting was that only 6 nurses got back to you, and between physios and EPs, 32 people got back to you. So, is that, I know there's physios in this room, and I expect nurses too. You know, is it because the physio or the exercise physiologist is the main person who collects the data or inputs the data, or would that be the nurse, or what was did you have any ideas why there was such a significant difference?
No, well, no evidence to back up my opinions, but I would say because we have a lot of physios that run, particularly in the rural setting, there's a lot of physios that run it, and the other big responders were CPS, so community physio services. So again, I think that bumps up our numbers a lot in that respect.
Community, that's where my thoughts were going off in rural and remote. You know, you don't have a whole multidisciplinary team. Sometimes it's just you. So, so that was my thoughts too. And the double handling is definitely something, you know, that we, you know, you keep it paper-based and you keep it. It made my thoughts go to AI. Has anybody thought of AI in this space in terms of being able to manage any of that data collection?
I hadn't actually thought about it in this context, but interestingly, I was filling in some paperwork for an allied health appointment that I have this afternoon, and one of the consent things was, do you consent to us using AI to help with writing notes? And I was like, oh, that's really interesting, and not something I considered. I don't think I have any issues with it, but I definitely think it can help in that reducing that double handling. How that would look, I don't know.
But I really like that you just said that they asked for your consent.
Yeah.
Because I think that's the really important part with AI, is that people have to consent if it's not human in the background. Yeah. The other thing I had, if no one else, I'm kind of hogging the questions here, but if no one else had the question, I did the ICCPR training, and I have fed back to everyone that the you mentioned PHQ 2s and 9s, etc. Because the ICCPR training is global, when you take the test with that and the mental health module states that you could only use a PHQ 2 or 9 if you were a psychologist or a psychiatrist. And so I have brought that up with ACRA and so CHD, because the disclaimer at the beginning says this training is global and therefore there will be differences. But yeah, so I just worry about the standardization of that with data collection. Do you see any problems there?
So Jess, I did the training as well, and it's interesting that you pull that one up, because I interpreted that messaging as you could only do the screening if you had someone to refer to, not that you had to be a psychologist or psychiatrist.
No, actually, you had to, because I had to lie to pass the test. I didn't want to miss out on my points and get my grade, so I had to say that I could do it as a nurse, and therefore I got the correct answer. So yeah, I mean, we can both look back at that, but I just
So in relation to the depression screening
for new practitioners,
So in relation to the depression screening, there is options to check other screening tools that may be used. It's just I chose that one in particular to embed into it as something that could be assessed then and there, because it is the most common one that is used.
Good. So I think obviously the hardest part of this is having everyone on the same platforms. You know, and that's the real the really difficult part. If everybody was just on the same platform, it would be really quite easy. Anyone in the room want to tell us which platform they use or any troubles they've had with collecting data? I think we've got a shy group today. Any questions at all you can pop them in the chat if you. I'm just wondering, Natalie, if everybody's able to come off mute. Maybe I'll have to take them off. No. I don't think there are. Doesn't seem like there's other questions for you, Nikki. Really interesting and really important, I think, to share this recording with your work colleagues so they can all see what the, what's being collected and what the plans are. And I wish you all the best with your Catalyst grant.
Yes, hopefully. I think they are planning on redoing this survey later this year as a follow-up to see if anything's changed. So I think it'll be interesting to see how the services that are still running have changed.
Yeah, and that was another point I was thinking. So the quality indicators came out in June 2021, and your survey was later that year.
Yeah.
So, as with anything new, it does take time to filter through. And then I guess COVID was in the world then, and it's just, yeah, everything needs that bit of time for people to be on board. And maybe, and that's why it's really important to spread the recording, because it feels like we should also, have an information day, including this, maybe a webinar. I don't know if there's anything at the conference around data collection, but the ACRA conference is what day? 9th and 10th or something of August.
I can't remember. It's too far for me to go to.
Yeah. But yeah, there might be something there around data collection. There usually is. And yeah, we just need to keep promoting this so that we can all get on the same page.
Question, if anyone's still actively listening, what would be a barrier? I'd say most people are probably saying no to being involved in the project, which is fair enough, I understand, but I'm interested in knowing why. Is it that you don't want to learn and use another software, particularly if it's only going to be for 3 months and then stop using it? Or would you, it's hard, but at the same time, we really want to get the WA perspective and input that would go towards a national strategy as well. Is anyone on board that are happy to share their barriers or dislikes like this idea?
Certainly for me, when I'm clinical, it's my least favorite part of the job. I like people. So I want to be with my patients, not writing all the bits about them. So I get that, it's that time away from the patient to enter the data, but without doing that, we can't advocate for better services because we haven't got anything to take to the bean counters to say cardiac rehab works. So we have to come to work each day and
that's why I designed the forms and the platform to be done while the patient is there. So it might be, it's, I guess, a minimum level data set. So you might complete all of that and then do whatever other questions and education you would in a different piece of software. So it's not something additional, it's to try and help what you're doing.
Yeah.
Having worked clinically as well, I understand that part. You don't want to do more work after the patient's gone.
Yeah, that's right. Yeah, if you can do powder with you, that's fabulous. Yeah. Oh, well done. Thanks, Nikky. If no one's got any questions, I just thank you all for attending, and please share the recording with your workmates. Thanks, Nikky. And thanks,
Helen.
Natalie.